Welcome. In this session, we'll be discussing about the clinical features of rheumatic heart disease. And under that, we will look at the St. John's criteria. Welcome all, my name is Wes Mwenyeri, and I'm the Daktari. Now, acute rheumatic fever, I told you, occurs in children, aged between 5 to 15 mainly. And the principal clinical manifestation is the carditis, pancarditis, involving all the three layers of the heart. There'll be a neuroendocarditis, a valvular endocarditis, a myocarditis, and a pericarditis. Now, nevertheless, about 20% of the first attack occur in adults. With arthritis in adults, arthritis is the predominant feature. Unlike in children where carditis is the predominant feature. Now, these symptoms usually begin 2 to 3 weeks after a streptococcal infection, okay? So I told you this delay is the time needed for the body to produce the autoantibodies, okay, which now mediate the immune response. I told you rheumatic fever is immunologically mediated disease, it is not an infectious process. And these are accompanied by fever and migratory polyarthritis involving the large joints. Please note that the polyarthritis involves the large joints where they become painful and swollen, okay? And they dissolve with no residual stability. So it is a non-erosive arthritis. Now, at the time of occurrence of the rheumatic fever, the cultures are usually negative, okay, because the lesions are free of the streptococcus. But you can use serological evidence by measuring the titers of antibodies against streptococcal antigens, such as mainly we use the anti-streptolysin O antibody titer and anti-DNase titers, okay? Now, the clinical manifestations of carditis include a pericardial friction rub, arrhythmias, myocarditis, which may be sufficiently severe to cause diffuse, cardiac dilation and the resultant functional mitral insufficiency and congestive heart failure. Nevertheless, less than 1% of the patients actually die of the acute rheumatic fever. Now, St. John's criteria. This, I need you to understand the St. John's criteria, okay? So St. John's criteria has major criteria, minor criteria, and you must, to conduct a conclusive diagnosis, you must have a supporting evidence of a streptococcal, a preceding streptococcal infection. Now, for the major criteria, you have 5, okay? 5, carditis, migratory polyarthritis of the large joints, subcutaneous nodules. Then you have the erythema marginatum, okay, and the Sydenham chorea, okay, and this chorea is just a neurologic disorder which is characterized by involuntary, purposeless, rapid movements, which was first observed in a girl known as St. Vitus. So it was named after her, St. Vitus's dance, okay? Now, the minor criteria include a fever, arthralgia. Arthralgia is not the same as arthritis. Arthritis is joint inflammation, itis. Ralgia means pain, so joint pain. EKG changes where you have a prolonged PR interval. Then you have elevated acute phase reactants. You use ESR and CRP. Okay, so those are the minor criteria. And supportive criteria, you must have serologic evidence of a previous streptococcal infection. So you use the ASOT, the anti-streptolysin O antibodies titer, or the anti-DNase, or you can do a throat swab and culture. At times you might find some cultures of colonies of the gas, the group A, beta hemolytic streptococcus. Now, how I remember this is the revised Jones criteria. The major manifestation, how I remember this is just by saying Jones criteria, okay? So JO for joint, and for the nodules, the subcutaneous nodules, E for the erythema marginatum, S for the St. Vitus's dance or the Sydenham's chorea, C for the carditis, the pancarditis. Now, for the minor manifestations, it is a fever and polyarthralgia. For the lab, what you see in the lab is increased ESR and CRP. These are the acute phase reactants used. Then in the EKG or the ECG, you see a prolonged PR interval. Now, note that migratory polyarthritis is the commonest major manifestation of Jones criteria seen clinically. So note that. Now, the supporting evidence of a preceding streptococcal infection must be there. And this is elevated or rising ASOT or other antibody titers, the anti-DNAs, positive throat culture, or rapid antigen test for group A streptococcus. Now, how you do a diagnosis is you use two major plus a supporting evidence of a preceding streptococcal infection, or one major criteria, two minor, and a supporting evidence of a preceding streptococcal infection. So this must be there, a supporting evidence of a preceding, okay? And also note that in the revised Jones criteria, you don't use elevated total leukocyte count as a minor manifestation, nor do you include scarlet fever as a supporting evidence of a recent streptococcal infection. Now, carditis. Let's discuss now the major criteria. Now, carditis involves the three layers, the pancarditis. Remember, it will involve the endocardium, myocardium, and pericardium. And now, the endocardium has both, we have muroendocardium and valvular endocardium. So there will be a valvular endocarditis, which will present as vegetations on the line of closure of the valves, mainly the mitral valve. And muroendocarditis will present as McCarran's patch, especially on the left posterior wall of the posterior wall of the left atrium, rather. Then you see the Ashkoff bodies, which are pathognomic of acute rheumatic fever. Then in the pericardium, there will be a fibrinous pericarditis, which will present as bread and butter. I showed you that. And note that the most affected nerve is the mitral valve, not nerve, the valve. The most commonly affected valve is the mitral valve. Then the rest is pulmonary valve, okay? And the most common valvular lesion is mitral regurgitation. And in chronic rheumatic heart disease, mitral stenosis. And mitral stenosis will present as the buttonhole appearance of the mitral valve, the fish mouth appearance of the mitral valve. Now, for the migratory polyarthritis, it is the earliest manifestation within 2 weeks after a history of sore throat, and it is the most common manifestation. It involves the large joints, the knees, the ankles, the wrist, and the elbows. It is migratory in that it will start at the ankles, then move to the knees, then the elbows and the wrists, okay? And those joints are usually red, hot, swollen, and tender, okay? And several joints are involved in quick succession, okay? And it is typically not deforming, okay? So it is an anerosive arthritis, and but sometimes can cause erosive arthritis, and in such case, it's called Jacob's arthritis, okay? Now, this arthritis shows a dramatic response to even small doses of aspirin or salicylate. Remember, aspirin is acetylsalicylic acid, which is another characteristic feature of the arthritis. So it is migratory, involving the large joints, and it responds even to small doses of salicylate. So children who have this can be given very small doses of arthritis. What do you want to give very small doses of arthritis, of aspirin rather? Maybe I've said something. I have a feeling I've said something wrong there. Now, let me repeat that. Why is it advisable to give children very small doses of aspirin? Because aspirin in children can cause Reye's syndrome. And so you have to give very small doses, and at the same time, you have to monitor, okay? You don't want the child to develop Reye's syndrome where you are trying to treat this. And Reye's syndrome is now is severe than this now. But remember, also, in children, there are other situations where you can use aspirin, such as children who suffer from Kawasaki disease, which is a form of a medium vessel vasculitis. Now, story of another day. Let's look at the Sydenham's chorea, or the St. Vitus's dance. It occurs due to damage of the caudate nucleus, more common in the prepubertal girls, aged 12, and it has a long latency period, ranging from 1 to 6 months after streptococcal pharyngitis. Now, it is a neuropsychiatric disorder. Now, the neurologic sign present as characteristic spontaneous purposeless movement and hypotonia, and these movements disappear during sleep. Now, the psychiatric signs are emotional liability, hyperactivity, separation anxiety, obsession, and compulsions. Okay, so it was first observed in a girl known as St. Vitus, and she presented with the chorea, the aimless, purposeless movements. Okay, you can see, you might think she's dancing, but she isn't. So it was named St. Vitus's dance. Okay, so it occurs due to damage of the caudate nucleus. Now, how can you elicit features of chorea? You can demonstrate the milkmaid's grip, where you ask the patient to squeeze your fingers as the examiner, and you will see contractions, irregular contractions of the muscles of the hand. You can also observe spooning and pronation of the hands when you ask the patient to extend the arms. Okay, then you can also see wormy and dirty movements of the tongue when you ask the patient to protrude the tongue. You can also examine the handwriting to evaluate fine motor movements of the hand. Okay, so ask the patient to squeeze your fingers as the examiner, and you will see irregular movements of the muscles of the hand. And you can also see spooning and pronation when you ask the patient to extend the arms. Now, erythema marginatum. Now, it is rare, occurring in less than 3% of patients with the acute rheumatic fever, but it is a characteristic rash, okay, which is erythematous, serpinous, so it is serpent-like, macular regions with a pale center, non-pruritic, please note that, so no itching. It primarily occurs in the trunk and the extremities, not on the face. Note that, not on the face. And because of this distribution, it is said to have a bathing suit distribution, okay? And it can be accentuated by warming, and the rash can migrate from place to place, okay? So, and it dissolves with no residual scarring, okay? So no residual scarring occurs, and you can see here it is. You can see the macular rash with a pale center, and you can see here where I was saying serpinous, like a serpent, okay? That you can see the distribution is on the trunk and the extremities, but never on the face, okay? Please note that. So that is why it has a bathing suit distribution. And another thing to note, it is non-pruritic, no itching. Now, the subcutaneous nodules are also rare, in less than 1%, okay? And they are approximately a centimeter in diameter, and they occur along the extensor surfaces of the tendons near bony prominences, and they are associated often with carditis, okay? And they are painless and non-tender. Now, they usually last for a week or two, then disappear spontaneous. And here we are. This is a subcutaneous nodule there. Okay, it is occurring near the extensor surface of tendons near bony prominences. Now, clinical outcome of now the rheumatic heart disease. Now, after an initial attack, the generation of immunologic memories occur, and in such patients, they become vulnerable to disease reactivation by any subsequent streptococcal infection. Okay, so the risk of getting rheumatic fever increases after an infection. Now, carditis is likely to worsen after each recurrence. Okay, and the damage to the valve is cumulative. Now, chronic rheumatic carditis is not clinically evident until years or even decades after an initial episode of rheumatic fever. So you might have a rheumatic fever at the age of, say, 10, but the chronic rheumatic carditis, such as mitral stenosis, might present even when you are, say, 20. So it has taken a decade. Okay, so at the time, the signs and symptoms of valvular disease depend on the cardiac valve involved. And please remember the frequency by which the valves are involved. Now, in addition to various cardiac murmurs, cardiac hypertrophy and dilation, and congestive heart failure, patients with chronic rheumatic heart disease often have arrhythmias, particularly atrial fibrillation in the setting of mitral stenosis, okay, and thromboembolic complication due to atrial neurothrombi. Remember, when you have atrial fibrillation and also you have mitral stenosis, so there will be the mitral regurgitation, the atrium will undergo dilation, and combination of atrial fibrillation and mitral regurgitation will lead to increased volumes of blood within the atrium, especially the left atrium, and these forms are a fertile substrate for the formation of a neurothrombi. Now, in addition, uh, um, scarred and deformed valves are more susceptible to infective endocarditis. Okay, please note that. Now, the long-term prognosis is highly variable. In some cases, a relentless cycle of valvular deformities ensues, yielding hemodynamic abnormalities, which begets further deforming fibrosis. Now, surgical repair or replacement of diseased valve, the mitral valvuloplasty, has greatly improved the outlook for patients with rheumatic heart disease. So that is good news. And I think after saying the clinical outcome, we can say that we have completed that. And I hope you have understood the St. John's criteria. Please understand that. So, and thank you for your attention and time, and follow for more of med content. So, thank you.